Physical therapy management of the surgical patient entails many components of communication between the therapist and physician, therapist and patient, and therapist and the discharge planning personnel. Among those concerns are understanding of the surgical procedure, exactly what has been done to the patient, the chances or complications involved with the procedure for difficulties or complications following the surgery. Also, patient expectations and post-op requirements with regard to mobility in the home and length of recovery. Patients often do not understand their length of rehabilitation and time before they return to their previous level of function. And finally, medical complications need to be addressed at all times, especially in the immediate postoperative phase. First thing we'll do is look at fixation and fracture types, just for a general understanding of surgical interventions with fractures. Generally, fixation devices, or devices that reduce a fracture or bring it back into alignment, are called stress sharing or stress shielding. A stress sharing device allows micromotion and therefore some callus formation occurs. A stress shielding device basically takes all of the stress and very little motion or no motion is allowed or involved at the fracture site, and healing is slower and usually additional support is required. But if you think about those two types of devices, let's just look at some examples. You'll see things like intermedullary rods and nails that share stress. Again, callus formation occurs with those. Here's examples of an intermedullary rod with the shaft fracture of the tibia. And interestingly, you can see at this intermedullary rod locking devices proximally and distally. This prevents rotation in the long bone. Compression plates are another examples of stress, are an example of a stress shielding device. Again, slower fracture healing and longer periods of non-weight bearing. Buttress plates, a little different, are stress sharing. It sort of has a lag screw, which is a threaded screw to bring the ends of the fracture together. They create a good anatomic reduction or alignment of a fracture. And they're often used in tibial plateau fractures. Fractures in this area are usually treated non-weight bearing. And you can see an example of a lag screw pulling the ends of the fracture together in the tibial plateau, and you can understand why weight bearing has to be limited when you look at the articular surface of the joint. Pins, wires, and screws also provide partial immobilization, so they are stress sharing devices. Again, micromotions allowed, and often weight bearing is delayed or slowed. They're frequently used at the ankle and the patella. You can see a wire pulling the patella ends together following a fracture. Compression screws, again, stress sharing, fragments are drawn together, similar to that lag screw you saw before. And then sliding hip screws and plates, where you have angulated areas such as in the femur with a threaded screw pulling the area together and allowing fixation at the femoral neck here. Sometimes in areas like the distal femur, there are compression plates, which are again used with threaded screws placed along the long aspect of the bone, pulling the fracture fragments together. These are used sometimes with multiple areas of fracture, where each screw can go in and pull back the fracture area. You can see here a distal femur fracture and the reduction attained as a result of the compression plate. And then finally, patients sometimes have to have external fixators, where the fracture fixation occurs externally and the patient wears a device for a significant period of time, allowing very little, limited weight bearing often, stress sharing, uh, and slow callus formation. It's often used with open fractures that protrude through the skin. You see an external fixator of a tibial shaft fracture. So let's just talk about fracture types. There are many different ways to classify fractures specifically at joints. But if we think about fracture types, I think we can talk about 6 basic types. Comminuted, where the bone is broken into a number of pieces. Spiral, where the bone is twisted apart, which often happens in pediatric patients. Transverse fractures, which are fractures at right angle. Oblique fractures are at an oblique type of alignment across the bone. Avulsion fractures is where there's a fragment of a bone which is basically pulled off of the bone. This often occurs at insertions of bones such as the medial epicondyle of the humerus, the patella tendon, and even the calcaneus. And green stick fractures are bending type fractures where there's only a partial breakage. You can see a comminuted fracture here, multiple fragments. And here an avulsion fracture, the medial epicondyle. Sometimes these avulsion fractures are similar to the apophysitis types of cases we spoke about, where there's lack of ossification, but it pulls off so far that it's often called not only an apophysitis but an avulsion type fracture. Now later on, once the ossification areas are fused in a skeletally mature patient, sometimes these areas can be pulled off by a forceful contraction of the bone during some trauma. At the lower extremity, at the ankle, in the medial aspect of the ankle, sometimes deltoid ligaments are not sprained. Instead, there's an avulsion fracture of the medial malleolus because the deltoid ligament has such a strong attachment. Here you can see a spiral fracture through the distal aspect of the femur, and an oblique fracture through the fibula. This was the green stick fracture we spoke about before, where it's sort of a bending fracture. Again, often occurs in pediatric patients, where there's a compression on one side and a distraction on the other side of the bone. And then compound fractures, where there's a complete break of the bone with protrusion through the skin. Problems here, of course, as you would expect, are possible infection and contamination, and maybe some neurovascular components in these types of fractures. Let's look at femur fractures and talk about different types, and they're just anatomically based. Just some general guidelines. Know your weight-bearing status first. When you're on your clinicals, please be sure to know what the weight-bearing status is. Is it partial? Is it weight-bearing as tolerated, or is it non-weight-bearing? Again, unstable fractures and some of those stress shielding devices, and you don't have to be overly concerned about categorizing the devices. I just want you to understand the differences. But again, unstable fractures often non-weight-bearing. Generally, in fracture management, some early active and assistive range of motion is allowed, plus sometimes even submaximal isometrics. Not all the time, but sometimes. Again, you want to avoid stress through the fracture site, especially with rotational and torsional type movements. And during ambulation, if patients are partial weight bearing or weight bearing as tolerated, avoid pivoting and torsional type movements. Let's look a little bit first at femoral stress fractures. They occur gradually due to repeated stress, or sometimes in individuals with compromised bone density. And they can develop and progress into really complete and displaced fractures. And complaints are usually sudden hip pain, usually due to changes in training, changes in intensity, sometimes surface changes. It often accompanies an increased activity. You can see a femoral stress fracture with the CT scan here right at the femoral neck. Signs, again, pain in the thigh, inguinal, and groin area, more than a lateral area. Lateral femoral pain is usually thought to be trochanteric bursitis, but not all the time. And there's usually an empty end feel where they get pain before you feel tissue resistance. So that's sometimes the first telltale sign. And usually a bone scan or an MRI is needed because, as you'll see in some case studies, it does not always show with regular x-rays. Here's a JOSPT report in 2008 of a femoral neck stress fracture in a male runner. Negative anterior-posterior x-rays originally. So the first x-rays were negative, and he had pain in the groin area. But then a MRI shows increased signal intensity, where you can see the yellow arrow in the area of the femoral neck. And as it mentions, fluids represented by a high intensity or bright signal on this type of MRI image. You'll get more information on MRIs a bit later, but you can see the increased intensity of that signal. And then later on, 6 weeks after those first radiographs, what you see is slight cortical irregularity at that medial aspect of the femur. I think it's very hard to see here, but the point is the radiologist would read nothing in the initial films, but would read something 6 weeks later indicative of a stress fracture. Here's another example of a femoral neck stress fracture and femoroacetabular impingement. I don't think we've spoken about femoroacetabular impingement yet, but you can see again increased signal intensity on this MRI T2 image, a bony edema at the inferomedial right femoral neck. Okay, and another image, they see a mild, what they call a CAM type lesion, which is part of femoroacetabular impingement, and that means that there is a significant convexity, which not only predisposes the labrum to tearing or irritation or lack of continuity, but also may be a factor in the stress fracture as well. And again, 8 weeks after the initial MRI, focal sclerosis at that inferior medial aspect of the right femoral neck. So often in stress fractures later, it's seen on x-ray, but you need an MRI to actually show bone edema or the fracture itself. Here you can see a fracture right through the femoral neck. Again, what can happen to a stress fracture later on if it is not treated properly with the adequate amount of rest and limited weight bearing. So let's continue with that and talk about femoral neck fractures as they can become more involved and displaced and require surgery. So there's 4 types of femoral neck fractures. Incomplete in some valgus, non-displaced, displaced and varus, so you can think about the femur itself either moving into an abductor or an adductor position, and completely displaced. And those usually require a prosthesis, which is a replacement of the femoral head because of the fact that blood supply is disrupted from the trauma. And this is just a graphic description of different types of fractures: compression, tension, and displaced at that femoral neck. And if it's severely displaced, you can understand that the blood supply will be disrupted. Fixation with devices like we spoke about before, compression screws. So just some special considerations with regard to rehab. Non-displaced or minimally displaced fractures may begin weight bearing as tolerated immediately post-op. And displaced often has disruption of blood supply, and that's when they require prosthesis. Early partial weight bearing or weight bearing as tolerated for stable fractures. If unstable, no weight bearing will be allowed. Delayed or no weight bearing ambulation for unstable fractures if open reduction internal fixation as opposed to an endoprosthesis is used. So an endoprosthesis is just replacement of the femoral head. A total hip is replacement of the femoral head, as you know, in the acetabulum. And again, usually 12 to 16 weeks of bone healing. Here's a femoral neck fracture in a military trainee. So you can see the early radiographs certainly show displacement at that arrow. where the femoral neck is fractured and displaced. And what would you say? This is varus or valgus. Looks as if it's displaced in a varus position. Okay, and these are the frog view, where you can get a better view not only of the joint but also of the fracture. And you can see anatomic reduction and placement of the fixation device. That's a frog view, again showing that reduction. How about intertrochanteric fractures? We're moving distally down the femur. A little challenging orthopedically because they try to restore the shaft angle. Think about it. If you do not restore that shaft angle of the femur, what's going to happen? You're going to have a change in the alignment of the lower extremity for ambulation. You're also going to have a change in the length relationship with the abductor muscles. Bone healing, again, 3 to 4 months. So remember, these fractures take a while to heal. Patients who have continued pain 3-4 months after, it's often because healing is still occurring. And as they weight bear, they have some discomfort through that site. You can see the fracture and the fixation. Intertrochanteric fractures have some special considerations as well. As I mentioned, it's technically challenging. They often remain toe touch or non-weight bearing until healing is demonstrated. The psoas muscle is sometimes left free because think of it, the psoas muscle will actually have an effect on that fracture healing just by the contraction, even with daily activities and transfers. I mentioned before the length of the hip abductors can be changed. And again, as with all things, understand the weight-bearing processes with the surgeon, and in addition, consider the patient's tolerance to weight bearing. Now we move distally to subtrochanteric fractures, okay? Again, between the lesser trochanter and the proximal third of the femur. Bone healing, 3 to 4 months again. An intermedullary rod, locking screws, or sliding hip screws usually used. There's limited surgical exposure to preserve surrounding tissue, which is damaged significantly in the injury. So it has some technically challenging concerns. And you can see the areas of fracture and the areas of fixation, again, with compression screws pulling the areas together. Here's an atypical subtrochanteric femoral fracture reported in JOSPT. Okay, look at that amount of displacement and varus. Okay, you can see the preoperative displacement and the postoperative reduction with, again, an IM rod and a compression screw, as we said before. Interestingly here, the interesting thing about this is they looked at bone density readings, and it appears, as you read the caption below this, that an image taken 1 month prior to the patient's fracture demonstrated a lateral cortical thickening in the area of the arrow. So that's suggestive that maybe there was some impending fracture information here. And that's often you'll hear patients say they don't know why they were walking and their leg just gave way. Well, sometimes patients fracture before they fall, and you can see that subtrochanteric area weakening in response to stress, and then the fracture occurred right in that area. Interesting case in JOSPT. This is a patient referred for knee pain who had no signs at the knee, and the physical therapist referred that patient to an orthopedist, or back to the, I don't think it was initially referred by an orthopedist. I don't recall the exact nature of the case study, but you can see a patient referred for knee pain who actually had a comminuted impacted fracture of the proximal femur. So trauma, knee pain, antalgic gait, but the problem was related to the hip, although the patient was referred for referred pain to the knee. Just general guidelines. These do not have to be memorized, but they can help you when you are seeing postoperative patients in the hospital. Early stages in the hospital, things like bed mobility, transfer training, and safety. Sometimes submaximal isometrics are allowed, gentle hip and knee range of motion ankle pumps, and again, non-weight bearing, toe touch, or partial weight bearing, as I say above, based upon the surgeon's orders. Phase 2, usually they're home or in a skilled nursing facility or subacute facility. Generally passive range of motion, active range of motion to the hip, again, limiting motion to not stress the area, and weight bearing can vary. Progression beyond 4 weeks depends upon the unique needs of the patients and goals. Weight bearing status is a primary limiting factor, remember that. Safety is a big concern when promoting progression or function, and gait recovery to normal parameters is very slow in the elderly patient especially. Moving distally, femoral shaft fractures, usually a rod and locking screws that I mentioned before. The locking screws to prevent rotation or movement along that transverse plane. Again, weight bearing can vary. Partial or weight bearing is tolerated if it's a stable fracture, 3 to 4 months healing. So that's pretty much across the board. You can see that shaft fracture. Distally, we have supracondylar fractures, but again, these now become intra-articular fractures because these supracondylar fractures can and often do extend into the articulation at the knee. Bone healing, 3 to 4 months, and fixation can be stable or unstable based upon the number of fragments dictating the weight, and that dictates weight bearing. Here's a patient that you don't have as good an image as I would like, but this patient ended up with about a 10 to 15 degree knee flexion contracture due to a distal femoral fracture, again with fixation like you just saw. A couple of things about hip fracture rehabilitation. The recovery depends largely on the pre-fracture health and function of the patient. Elderly, mental, and physically challenged patients carry a high morbidity risk or a high risk of not attaining a good level of function. In 2010, a study by Pereira showed that use of physical therapy was one factor which helped decrease mortality after hip fractures in a study of 246 patients. So not just morbidity, but patients also had less incidence of mortality by improving their mobility and getting therapy. And don't forget that discharge planning is a major part of your role in the acute setting. Your interaction with social service and what the patient's next level of function and need will be is critical in decision making. So right from the get-go, hospitals want to know where the patient's going after discharge, and you are the person that they're going to be asking that about. Again, hip fracture rehab varies widely. That's why I just gave you guidelines, key things. Weight-bearing status, be sure it's correct. Communicating with the surgeon if you have any problems. Watching for medical complications, and understanding that it is slow. Okay. In a systematic review of 55 studies, positive outcomes are associated with quadriceps strength, balance exercises, and light aerobic training. Okay. And later on, another case study reported that high-intensity rehab 2 months after discharge from formal PT led to improved outcomes of ambulation and balance. And what dosage did they say? 3 days of PREs and 2 days of balance training per week for about 2 months. So I think we have some good evidence that fracture rehab, A, is essential, B, is critical in that early phase of discharge planning, C, has an effect on morbidity and even an effect on mortality. So we have a unique role to play and a very important role. And let's not forget that. Patella and tibial fractures. Patella fractures usually tension wire fixation. They can be displaced or non-displaced. Treatment goal is alignment and stability, internal fixation with a wire sometimes, and bone healing takes several months. Usually weight bearing is allowed as tolerated while in an immobilizer. Fracture fixation is often determined based upon the amount of displacement. It's a surgical decision. And there can be an influence of poor fracture outcomes based upon non-compliance with restricting range of motion and proper weight bearing early on. The key thing here is usually limitation of the amount of mobility post-operatively, especially in the first month. Usually they don't allow it to go past 90 degrees because they feel that'll stretch the area significantly, and also limiting quadriceps contraction. Because think about it, if you go beyond 90, you're going to add stress to the fracture site by stretching it, and if you go beyond, and if you add active contraction, you're going to pull one end of the fracture from the other. So those two things should be kept in mind. Passive range of motion and limited to 90 degrees. Key points and take-home messages with patella fractures. Beyond that, range of motion is allowed to increase. Weight bearing is tolerated usually. And again, limiting active contraction of the quadriceps. At 9 to 12 weeks, usually closed chain exercises for the quad, because again, think about it, open chain exercises can specifically add increased tension to the fracture area. So closed chain for patella fractures initially to get quadriceps strength. Tibial plateau fractures, as I mentioned before, non-weight bearing often for significant periods of time. Usually non-weight bearing for up to 12 weeks. Early limited range of motion is allowed, but no varus or valgus stresses. Treatment objective surgically is to restore anatomy. Patients carry a high chance of osteoarthritis of the knee following these. Tibial shaft fractures similar to femoral shaft fractures, intermedullary rod and a locking screw. Tibial osteotomies are fractures which are surgeon-induced to realign the knee. So generally, if someone has a severe varus of the knee, for example, there will be a lateral closing wedge where there's a wedge created in the lateral tibia, and that wedge is then closed to allow alignment into more of a position of valgus. These patients usually non-weight or partial weight bearing for up to 6 weeks, and range of motion of the knee is usually allowed initially, but quad and lower extremity strengthening is delayed. And you can see a lateral closing wedge. You can understand that this patient is in varus. A wedge is removed of the tibia, and then it's secured with fixation like a plate, as you see here. Total knee replacement. Generally, almost 400,000 total knees are performed in the U.S. Every year, and probably more at this point. As the baby boomer population ages, more and more are needed. It's effective treatment for osteoarthritis after conservative treatment has failed. Arthroscopic treatment is beneficial prior to this if there's meniscal pathology, but if there's just osteoarthritis, it has no impact on a positive outcome. And an osteotomy is appropriate, especially if there's unicompartmental disease. Think about it. It's appropriate if the medial joint is arthritic and you're desiring to decrease compression or forces in that area. Total knees will have a condylar and a tibial component. Usually the tibial component is plastic, condylar component, and the condylar component is metal, and it does allow the surgeon to restore alignment. Numerous implants and fixation devices are available. You'll see these as you get into the clinic, and you'll be aware of them sometimes, and sometimes you won't be. You'll just have the situation of what the patient's weight bearing is. Usually its weight bearing is tolerated, the range of motion that's allowed, and the ambulation restrictions. Sometimes there are unicompartmental total knee replacements. That's where only one compartment, medial or lateral, is replaced. There are some shortcomings due to arthritis development in the other compartments, but traditionally full total knees are performed, and over 90% of the patients do have good results. And there you can see a unicompartmental knee replacement. Complications in total knees you should be aware of: infection, instability, malalignment, stiffness, reflex sympathetic dystrophy or CRPS, patella malalignment, and DVTs. Really important, DVTs are a frequent complication following orthopedic surgery, and for that reason, Patients are sometimes placed, or often placed, I think the protocol is to place them on a blood thinner, which is an aspirin or a Plavix or an equivalent. Minimally invasive surgeries or newer techniques with less dissection and faster recovery. Just some general things on total knee rehab. Range of motion is allowed early. Weight bearing is tolerated with crutches or a walker. And transfer training is stressed early on, especially in the hospital. Key thing on range of motion is to restore knee extension. Flexion usually comes, but flexion contractures are a concern. Okay. Patients are discharged rapidly from the hospital and usually placed on subacute or home care. Again, flexion contractures be aggressive. Early positioning is important to maintain extension. Be aware of underactive quadriceps and avoid overemphasis on flexion and stretch weakness. Medical complications, as I mentioned, wound infection, DVT, pulmonary embolism, perineal neuropraxia, persistent joint effusion, and lymphedema.